Very warm good morning to all the respected teachers, seniors, and my dear colleagues. I'll be starting with today's discussion on the background of compound genomic alterations of TP53, P10, and RB1 tumor suppressors in localized and metastatic prostate cancer. The prostate cancer treatment has advanced greatly in the past decade. Genetic and genomic testing, which started as a research tool, is now a standard part of care and included in key guidelines. It started with the discovery of association of 10q loss in 1985, and now we are in an era where we can easily locate the gene associated with the mutations. A key challenge in prostate cancer management is the lack of risk stratification based on patient's genomic profile. Currently, we classify metastatic cases as high or low risk using factors like disease volume and metastasis timing. While this is straightforward, these methods don't account for molecular drivers unique to each patient. Research shows that genomic differences significantly impact how prostate cancer behaves. For example, HRR mutation in BRCA1 or 2 are both prognostic and predictive of PARP inhibitor responses. Today, we'll be discussing about other genetic alterations, which is TP53, RB1, and P10 linked to prostate cancer. We know the serious genomic and phenotypic heterogeneity in prostate cancer. There is accumulation of genomic changes during organogenesis, which later in life could lead to tumor focus of various kinds driven by different genetic mutation. These driver mutation will determine if the cancer would be located to a local site, would metastasize to lymph node only, or given the systemic therapy, will become resistant to the therapy. So combining what we know till now is there is a primary prostate cancer which harbors some de novo mutations. The systemic therapy that we give will also drive the pathway for further mutations. These mutations could be in the cell cycle, including RB1 cyclin-dependent kinase mutation, or in the DNA repair pathway, which includes the very known BRCA1, BRCA2, ATM, RAD51, FANCA, MLH1 or MSH2, or the most commonly associated changes in the CRPC is in the AR pathway, which includes the amplification, mutation, or deletion in these pathways. Other pathway includes the PIK3 pathway, where there is lots of P10, the tumor suppression gene, or mutations in the WNT pathway. So if we see at the genomic landscape of the prostate cancer, as we move from localized prostate cancer to metastatic CRPC, the density of these mutations keeps on increasing. The highest histogram that we can see of is related to the androgen receptor pathway, and amplification in these receptor is the most common cause of secondary changes in advanced CRPC. Our topic of interest is TP53, RB1, and P10, and the same applies here. As we move from localized to metastatic states, these mutations density keeps on increasing. So the key genetic changes are the loss of chromosome region 8p and 10q, 13q, 17p, or there is loss of tumor suppressor genes P10, RB1, TP53. There are also other pathways which includes gene fusion, TMPRSS2 or ETS transcription factor gene fusion. Then the most common is the androgen receptor role, because we know that the prostate cancer is driven by androgens. So there could be reactivation in the CRPC, which is due to gene amplification, mutations, splice variants, or changes in the androgen biosynthesis, or other cofactors associated. The new mechanisms that are coming to be known are amplification of the AR upstream enhancer or AR gene rearrangement. And in advanced CRPCs, the tumor lose their AR dependence and they develop neuroendocrine features. So the primary changes, the changes in the primary prostate cancer include somatic mutations, the changes in DNA that occur after conception in genes like SPOP, FOXA1, and TP53. There could be copy number alteration, that is changes in the number of copies of the gene MYC, RB1, P10, CDH1, or oncogenic structural DNA rearrangement, chromoplexy, which includes ETS gene fusions.
So this SPOP gene is actually very important. It predicts long-term response to single agent androgen inhibitor itself. For example, if we find that SPOP gene mutation is present in a particular patient, we can give single agent therapy, for example, abiraterone, enzalutamide. So we don't require triplet therapy in those patients like docetaxel combination with abiraterone. So that helps in reducing the treatment without compromising the efficacy.
We had a study which showed the differential impact of tumor suppressor genes alteration and treatment outcomes in metastatic hormone-sensitive prostate cancer. The number of patients were 97, and there were two subdivisions: ADT with abiraterone and ADT with docetaxel. In patients who had the tumor suppressor genes normal, the PFS was 23.2 months, and with altered, any one of the genes, if they were altered, the PFS decreased to 8 months. Similarly, in the docetaxel group, the PFS with normal tumor suppressor genes were 9.5, and which reduced to 7.8 with altered TGS. Now, we also have some data regarding genetic profiling of hormone-sensitive and castration-resistant prostate cancer and indication of genetic mutation prone to castration-resistant prostate cancer. So, taking out the gist, the top 3 mutated genes in sensitive prostate cancer were FOXA1, CDK12, and TP53. And mutations in the pathway included DDR and HRR, about 50% DDR mutations and HRR 44%. The common mutation in the CRPC samples were androgen receptor, APC, regulation of stem cell pluripotency, and EMT transition. CRPC early progression risk prediction panel included genes MSH2, CDK12, TP53, and RB1. Now, the genetic changes in the metastatic setting, most common is the AR pathway. The genomic alteration in AR, TP53, RB1, and P10 are enriched during disease progression. Approximately 90% of metastatic CRPC harbor clinically actionable molecular alteration, including AR signals, DNA damage repair, and PIK3 signaling. Also, we have some racial differences, like in Asian population, we have higher FOXA1, CDH1 mutation and lower TMP RSS2 fusion and P10 loss. In Western population, we have lower incidence of these mutations and higher incidence of the fusion genes. But this was a recent research paper published which shows that these 3 combination mutations were linked to worse survival in prostate cancer. If any one of the following mutation is present, the median overall survival decreased from 67 to 35.8 months. Now we have a subset of a patient with metastatic castration-resistant prostate cancer that develop androgen-independent phenotype, which is characterized by poor response to androgen deprivation therapy, early and extensive visceral metastasis, low PSA levels, and significantly worse cancer-specific and overall survival. These are known as aggressive variant of prostate cancer.
AVPC.
AVPC.
So this is a very important terminology which has now come up, and we see it quite frequently. So what happens? We see some patients with low PSA, but at the same time they are progressing in the scans. So this is a very important phenomenon. We always try to exclude the small cell transformation, but sometimes we don't get a small cell transformation. So then, even with the small cell or without the small cell, it is labeled as AVPC. But it is not mandatory to have small cell transformation to call it AVPC.
So low PSA means it can be normal?
PSA can be low, borderline low, 1, 2, like that.
These aggressive prostate cancer cells often show dedifferentiation, sometimes called anaplastic prostate cancer. Neuroendocrine features are frequently observed in these cases, even though de novo changes are rare. However, treatment emergent neuroendocrine prostate cancer, TNEPC, where neuroendocrine feature developed during treatment is much more common. Identifying AVPC is crucial as standard taxane-based chemohormonal therapy show low response rate. More sophisticated platinum-based combination therapies are recommended for these patients. So we had a study which included Taxol plus carboplatin for treatment of men with metastatic castration-resistant prostate cancer. Here, a subgroup patients were analyzed where the patient was stratified for the presence or absence of AVPC clinico-pathological features and the effect of this aggressive variant prostate cancer phenotype on response, which was included as a secondary outcome. We also had a AVPC-MS criteria, which was a sample with abnormal results in at least 2 of the 3 tumor suppressors, met the criteria as aggressive variant of prostate cancer, molecular signature by immunohistochemistry. The presence of this AVP-MS assessed by immunohistochemistry or ctDNA in post-hoc analysis was associated with clinically meaningful improvement in both median progression-free and overall survival with the addition of carboplatin to the cabazitaxel.
So there is at least two of the three.
Yes, yeah. These required at least two of the three. So this is very important actually, because clinico-pathologically, when the data was analyzed, AVPC-C did not lead to any benefit by addition of carboplatin, but when it was by AVPC-MS criteria, when it molecular signature was positive, any out of the three were positive, then addition of carboplatin led to a doubling or tripling of the overall survival. So it is highly meaningful in terms of improving the outcomes for patients as well.
The integrative clinical genomics of advanced prostate cancer. It was a study done in published in May 2015, where around 157 cases were sequenced after pathological review. The biopsy sites were lymph nodes, bones, liver, and other soft tissue. In the histology, we found that about 96.4% of the patient has usual high-grade prostate adenocarcinoma, 2.9% shows usual prostate adenocarcinoma with some differentiation, and only 0.7% has small cell neuroendocrine carcinoma. Approximately 90% of the metastatic CRPC harbor clinically actionable molecular alterations. So, summarizing the data from the previous study, the most commonly gain in the mean copy numbers were 8q and androgen receptors, and most common loss of copy numbers included RB1, TP53, and PTEN. Other genetic aberrations were gene fusion associated with ETS. And if we see the figure C, the primary prostate cancer is enriched with mutations like SPOP, PTEN, APC, BRCA2. And as we move towards the CRPC enriched population, the most commons are associated with androgen receptor mutations and TP53 mutations. So to summarize, when we have a patient, we do a tissue and a liquid biopsy, genomic profiling is done. The clinical outcomes indicated of poor outcomes are alteration in AR, TP53, RB1, and cell cycle neurocrine features, and better outcomes are associated with SPOP mutation, which is common in Asian population. Actionable alterations are AR signaling PARP inhibitors for BRCA1 or 2 mutation, anti-PD1, PD-L1 therapy for MSI high, or AKT inhibitors for PTEN losses. Thank you.
Thank you, Shreya. So I think we can move to the methods part. So this was a good background, which gives us a significant idea. Chaitanya, you can go ahead. Make it full screen.
Good morning, everybody. Am I audible, sir?
Audible and visible, you can go ahead.
Yeah. So compound genomic alterations of TP53, PTEN, and RB1 tumor suppressor genes in localized and metastatic prostate cancer. So this was a study. We'll go through the methodology. The study population, the patients who were treated at Dana-Farber Cancer Institute in Boston with a diagnosis of prostate cancer between 1998 and 2016. They underwent an oncopanel sequencing of their tumor tissue from the prostate primary site and other metastatic site as well. So then the study population was decided in 3 retrospective clinical cohorts. So the first cohort formed of a localized castration-sensitive prostate cancer cohort, non-metastatic disease at diagnosis, and curative intent local treatment with or without adjuvant androgen deprivation therapy. So this cohort excluded actually men who were primarily managed by active surveillance. Then the second cohort was of a patient of metastatic castration-sensitive prostate cancer cohort, which comprised of patients who were either de novo metastatic or metastatic relapse after prior local therapy, like including salvage radiotherapy as well. So this group excluded patients who received ADT for biochemical recurrence and who were managed without a curative intent. The third cohort they studied retrospectively was of that of metastatic castration-resistant prostate cancer, in which metastatic tumor biopsy was done within 6 months prior to or after the date of castration resistance, as defined by the PCWG3 criteria. So these were the three cohorts formed. So we can see that the profile sequencing, a total of 244 patients were there, out of which the localized cohort formed about 205 patients, with metastatic cohort for castration sensitive forming 26 in number, and castration resistant eventually were found to be 48 in number. So, sequencing of formalin fixed paraffin tissue from biopsies of patients with localized or metastatic disease using the OncoPanel was done. So, this OncoPanel, which Dana-Farber Institute utilized, that was a targeted, massively parallel sequencing of over 300 cancer-related genes was there, including the mutations of our interest in this. So previously, which were previously validated by a laboratory at the Brigham and Women's Hospital, evaluating somatic mutations, copy number alterations, and structural rearrangements. Tumor mutational burden was also estimated by determining the number of non-synonymous somatic mutations that occurred per megabase of exonic sequence data across all genes on the panel. So to estimate the percent of genome copy number alterations, an internally developed tool was used to calculate the fractional coverage of specific genomic intervals compared with median fractional coverage obtained in a panel of 152 tissues of non-neoplastic samples. So patients with any significant alterations in TP53, P10, or RB1, or a combination of either of them, were classified as tumor suppressor gene altered. The primary analysis adopted the definition of tumor suppressor genes altered, monoallelic or biallelic, as any significant mutation and one or two copy deletions. So the secondary analysis restricted this definition to biallelic inactivation only, defined as significant mutation and homozygous deletion. How they analyze this data? They assess the association of this tumor suppressor gene biomarker status in patients having tumor suppressor gene alterations compared to those with negative, and unique gene hits were assessed. So whether there was 0 hit, 1 hit, or 2 to 3 hits respectively, and they assess this with the clinical outcomes. So time to event endpoints in the localized castration sensitive prostate cancer, this started from the follow-up from the time of biopsy preceding local therapy and included event-free survival, which is defined as the time from the prostate specific antigen relapse till the time to prostate specific antigen relapse, metastasis, or death. Time to CRPC was also calculated. Overall survival was defined as the time to death from any cause, and time from ADT commencement for metastatic disease to CRPC and death, which was overall survival, were endpoints in the metastatic castration sensitive cohort, and duration of first line CRPC therapy and overall survival were endpoints in the castration resistance cohort. So they utilized the Cox proportional hazard regression model, and they assessed the endpoints. The proportional hazard assumptions were assessed using the scaled Schoenfeld residuals. Distribution of endpoints according to biomarker status or unique gene hits were estimated using the Kaplan-Meier method. So assuming that an analytical cohort of 205 in the localized with 73%, 73 of them, 36% event-free survival events, and 39% patients with tumor suppressor gene alterations. A power of 80% was considered to detect a hazard ratio of 2, comparing tumor suppressor gene altered versus the tumor suppressor gene negatives. So the results of this study, which they conducted a retrospective nature, suggestive of that the most of the localized castration sensitive prostate cancer patients, they had clinically significant tumors, which was ISUP grade 2 to 3 grade were forming 115 of them, that is 57%. ISUP grade 4 was formed about 26% of the patients, and organ confined stage T1 was 120 and stage T2 was 52 patients. So 70% of the patients, that is 30 of them, with metastatic castration-sensitive prostate cancer, they presented with de novo metastatic disease, and 50% of them met the high-volume disease criteria. Similarly, in the castration-resistant cohort of 48 patients also, 53% of them met the high-volume disease criteria. So this was depicting the frequency and distribution of the TP53, RB1, and PTEN alterations. So we can see that various co-alterations were also studied. In the localized, they were 14 in number, that is from the 7%. In the as we go towards the metastatic castration-resistant group, the co-alterations as well as the mutations, their percentage increase. And the unique tumor suppressor gene hits which were studied, no hits over there in the localized region. And similarly, tumor mutational burden was studied as well, with percent of genome copy number alterations as well. So, coming to the results, tumor suppressor gene alterations, alterations in key genes which we were of interest, like TP53, PTEN, or RB1, they were significantly found more in advanced stages of prostate cancer. Like 92% of the castration-resistant cohort showed these mutations, as compared to the localized cohort, which showed only 39% of them showed the mutations. So these genetic changes were linked to more aggressive disease progression and poorer outcomes. Considering the survival outcomes, if we studied the event-free survival, patients with tumor suppressor gene alterations had a median EFS of 2.6 years in the localized cohort, compared to 7.6 years for those without such alterations. The overall survival also was studied, which showed that the presence of tumor suppressor gene alterations correlated with a shorter overall survival, indicating that it's a more aggressive disease course. Tumor mutational burden. The higher tumor mutational burden was associated with advanced disease stages and poorer outcomes in this study. The percentage of genome copy number alterations was linked to more of an aggressive disease and had a worse survival outcomes. Cumulative gene hits, which was studied, there was increased risk with more hits. The study found that the risk of relapse and progression to castration-resistant cancer increased with the number of tumor suppressor gene hits. Patients with 2 to 3 tumor suppression gene hits had a notably higher risk of relapse and a shorter time to the castration-resistant prostate cancer. So these findings do depict the importance of tumor suppressor gene alterations in the progression and prognosis of prostate cancer. And this highlights the potential for multiple targeted therapeutic interventions. Coming to the localized cohort disease, men who were having any of the tumor suppressor gene alterations, they were having nearly twofold increased risk of relapse. Tumor suppressor gene alterations were associated with a shorter time to the castration-resistant prostate cancer. Individually, TP53 and PTEN alterations were associated with relapse. Cumulative tumor suppressor gene hits were associated with an incremental risk of relapse and the risk of castration-resistant prostate cancer. Copy number gene alterations and tumor mutational burden, they were prognostic for relapse and castration-resistant prostate cancer. So the cumulative gene hits showed lower hazard ratios and no significant association with event-free survival or the time to castration-resistant prostate cancer. The low rate of compound biallelic tumor suppressor gene loss in localized castration-sensitive prostate cancer did not permit an analysis of these increasing gene hits. So this is the localized castration-sensitive prostate cancer groups with a biomarker positive and the unique gene hits which were studied. Coming to the metastatic castration-sensitive cohort, there was evidence of inferior OS with tumor suppressor gene loss in the metastatic castration-sensitive cohort, with a 4-year survival rate of tumor suppressor gene alterations being 64%, as compared to almost 100% who survived the 4-year in tumor suppressor genes who were negative. The presence of a tumor suppressor gene mutation or deletion was significantly associated with an increased risk of death. So the increasing tumor suppressor gene hits led to an incrementally poorer overall survival, with 4-year survival rate for tumor suppressor gene hit 1 was 85% as compared to those with 2 to 3 hits having 43% 4-year overall survival and no hits having 100% overall survival of 4 years. So there was no indication of any association, however, between the tumor suppressor gene alterations and the time to castration-resistant prostate cancer in this metastatic cohort. Regarding the castration-resistant cohort, the median follow-up period was 4.1 years. The median duration of the first-line castration-resistant prostate therapy was short at 6 months, with majority of patients, 64%, going on to receive first-line androgen receptor-directed therapy, out of which conventional non-steroidal anti-androgens were 35%, abiraterone 19%, and enzalutamide 10%. This study was not powered to detect a significant difference in the overall survival in the castration-resistant cohort, but there was an evidence of an increased risk of death with tumor suppressor gene alterations, with a median overall survival of 4.5 years, hazard ratio of 3.26. And the cumulative gene hits, however, these associations did not meet any statistical significance. So to validate the findings of the study, the P10, T53, and RB1 alterations. A separate localized prostate cancer cohort was profiled for the copy number gene alterations, and the distribution of tumor suppressor gene alterations was similar to that found in the Dana-Farber Cancer Institute cohort. So 44% patient had tumor suppressor gene alterations and 14% harbored 2 or more tumor suppressor gene hits. So increasing gene hits were significantly associated with relapse in this cohort as well. Thank you.
Thank you, Chaitanya. So I think you have highlighted the result section very well. The main highlight was it was so strongly predictive of responses and outcomes, even free survival in localized prostate cancer as well. So this is very important. Ritam, you can go ahead for the discussion part.
So is it visible?
Yes, it's visible. You can go ahead.
Good morning, everyone. So after the background and result part, now we are moving to the discussion part of this study. So as Dr. Shreya has discussed, prostate cancer is highly heterogeneous disease. And if we look into the molecular spectrum of prostate cancer, and this study published by the Cancer Genomic Atlas Research Network of 333 primary prostate cancers, 74% tumors fell into 7 subtypes defined by ETS fusion or mutations. There is substantial epigenetic heterogeneity, including a hypermethylated IDH1 mutant subtype. There is DNA hypermethylation. There is AR androgen receptor pathway activity, DNA repair defects, and PIK3 RAS pathway alteration. And there is some actionable lesion in almost 20% patients in PIK3 or MAPK pathway or DNA repair pathways. So as we are looking into the tumor suppression gene alteration in this study, so tumor suppression gene alteration are increasingly frequent in metastatic and castration-resistant prostate cancer. So it's almost 39% in localized CSPC, 63% is metastatic CSPC, and 92% in metastatic CRPC. And tumor suppression gene co-alteration, that is more than one tumor suppression gene alteration, was nearly universal in metastatic CRPC, with almost 73% compared to 28% in metastatic CSPC and 11% in localized CSPC. And half of them shows almost loss of all three tumor suppression genes. So if you look into the tumor suppression gene alteration and clinical outcome, in localized CSPC, any tumor suppression gene alteration had nearly a twofold increased risk of relapse with a event-free survival of 2.6 years versus 7.6 years in absence of any TSG alteration. And it's also associated with shorter time to CRPC with a median EFS of median time to CRPC is 9.5 months and is not reached in absence of any tumor suppression gene alteration. And in subset analysis, this event-free survival association is more pronounced in P10 loss and TP53 loss. Regarding the compound TSG loss, that means one or more than one TSG alteration together is found is 11% localized CSPC patient, suggesting that initiation of resistant disease can occur early in a subset of patients. And the hypothesis behind this is that early compound loss of TSGs results in aggressive disease marked by altered proliferative signaling and early genomic instability well before clinically overt castration resistance. So what is the prognostic impact of this compound TSG loss? So compound loss leads to more aggressive biology in preclinical models, and loss of TP53, P10 or RB1 drives some transdifferentiation to a androgen receptor independent pathway, resulting in anaplastic phenotype similar to neuroendocrine prostate cancer that nowadays is called aggressive variant of prostate cancer. And P10 TP53 dual activation in prostate progenitor or stem cell results in development of neuroendocrine cells and a tumor initiating phenotype. Whereas regarding RB1 and TP53 inactivation, either of these develop prostatic intraepithelial neoplasia, and dual inactivation of RB1 and TP53 leads to again neuroendocrine differentiation and rapid metastasis. And also RB1 and TP53 dual inactivation leads to anti-androgen resistance and lineage switch through upregulation of SOX2 protein, which is a reprogramming factor, notably seen upregulated in enzalutamide-resistant prostate cancer cells. Coming to other genomic factor, that is tumor mutational burden and PGA, that is percentage of genomic alteration. These are markers of global genomic instability, and these were significantly prognostic for relapse and as well as time to CRPC. And these findings in the current study were consistent with two previously published study, where it has been seen that PGA, that is percentage of genomic alteration, less than equal to 7.49, and copy number alteration less than equal to 5.4 was associated with better biochemical relapse-free survival. In the multivariate analysis of this study, adjusting for genomic instability with other clinicopathological factors in localized CSPC, cumulative TSG loss, this multivariate analysis didn't demonstrate a significant independent association of increasing gene hits and risks of relapse or castration resistance. And this could be explained by that cumulative TSG loss may be a representation of increased genome-wide mutational and copy number burden, but the upstream mechanism is unclear. On the other hand, cumulative TSG loss may be fundamental driver of genomic instability through aberrant genome maintenance and replication fidelity. But either of this association doesn't preclude a significant biological role of cooperative TSG loss in disease progression. So the interplay between all these three TSG and their alteration and the sequence is quite complex, and this remains an area of active investigation. Coming to the early implication of early TSG loss. So early TSG loss may well be significant in localized CSPC, and men with TSG alteration who underwent definitive treatment were at increased risks of relapse independent of clinical stage and ISUP grade in the study. Genomic profiling for TSG at baseline biopsy may identify tumors harboring compound alteration, and they are suitable, may be suitable for study of intensive systemic therapy like AKT inhibitors for tumors with PTEN loss or chemotherapy. In localized CSPC cohort, biomarker positive alterations in these genes largely being due to monoallelic deletion, suggesting that hemizygous TSG loss is prognostic in localized CSPC. Compound TSG loss in metastatic CSPC. So in metastatic CSPC cohort, it was evidence that compound TSG loss was associated with inferior WES. So 4-year WES was 64% versus 100% in TSG alteration absence. But TSG mutation or deletion was also significantly associated with increased risks of death. And increasing TSG hits, that is more than one, that is TSG 2 or 3 hits, leads to incremental poorer overall survival. So 4-year overall survival with single TSG loss was 85%. In 2 TSG loss was 43%, compared to 100% 4-year overall survival in absence of any TSG alteration. But there was no association between TSG alteration and time to castration resistance. Coming to TSG alteration in metastatic castration-resistant prostate cancer cohort, so there was increased risk of death with TSG alteration with a median overall survival of 4.5 years in this cohort, but cumulative gene hits was not associated with a poorer overall survival statistically. So these are the results of this particular study, but this study is not devoid of limitations. So it was a retrospective cohort. And that's why there was significant confounding factors, despite that outcomes were comparable with other prospective datasets. And in metastatic CSPC cohort, the investigators biopsied in a sequential manner that the prostate biopsy at baseline as well as in all subsequent progression. And this sequence metastatic biopsy may underestimate the TSG alterations. And due to polyclonality of localized prostate cancer and subclonal alteration of tumor suppressor genes, the tumor profiling may have resulted in underdetection of mutated subclones. And in absence of any paired germline data, the assay that has been used in this trial, that is targeted sequencing panel named OncoPanel, didn't allow for definitive determination of variant origin. That means whether it is a somatic variant or germline variant. And when this study took place, the multi-gene tumor sequencing panel in Dana-Farber was in a relatively nascent stage with limited follow-up in particularly CSPC cohort. So if we summarize this, the findings of this trial, the presence of genomic alteration in TP53, PTEN and RB1 and compound loss of genes in both early and advanced prostate cancer portends adverse prognosis, and detection of this alteration using efficient and affordable tumor sequencing holds potential to inform design of prospective therapeutic and biomarker trials for precision medicine and accurate prognostication by identifying high and low risk subgroups. And this particular study later paved the pathway for subsequent research in tumor suppressor gene alteration in prostate cancer. So this study published in 2020, the Newcrest et al. Demonstrated that TP53 and RB1 loss in prostate cancer attenuates the androgen receptor signaling and enhances the cell proliferation, but doesn't uniformly induce neuroendocrine phenotype. And patients with TP53 and RB1 dual loss are resistant to wide range of cancer therapeutics, particularly single agents, but response to PARP inhibitor and ATR inhibitor are likely reflecting that there is some enhanced replication stress associated with this dual loss. So in this study, combined TP53 and RB1 loss was associated with worse overall survival from time of metastatic biopsy, worse overall survival from the time of initiation of androgen receptor signaling inhibitors, and a shorter time on androgen receptor signaling inhibitor therapy. Coming to another study where it's a multi-center study of Guardian Genomic Network where impact of TP53, RB1 and PTN mutations was assayed from real world sample and based on NGS. And authors classified the patients into biomarker positive where there is at least one of the genomic alteration present, or biomarker negative when there is no genomic alteration. So it was seen that biomarker positive group has a lower survival. So 2 year survival was 78% compared to 84% in biomarker negative group, and 5 year survival was 46% compared to 66% in biomarker negative group. And a subgroup analysis has shown that at a minimum follow-up of 4 years, there was a greater difference of overall survival. That was 67.2 months in biomarker negative group compared to 35.8 months in biomarker positive group. So, as Dr. Shreya discussed about the aggressive variant of prostate cancer, so loss of all these tumor suppressor genes actually phenotypically presented by aggressive variants of prostate cancer. So initially the clinico-pathological criteria was presented from MD Anderson Cancer Center in 2017 ASCO. So there is a contrast in the clinico-pathological presentation of ABPC compared to conventional prostate cancer. So it mostly presents with small cell histology, though as Dr. Akhil has said, this is not exclusive. Compared to adenocarcinoma histology in conventional group, it exclusively presents with visceral metastatic spread compared to common bony metastasis, and is predominantly present with lytic bone metastasis compared to osteoblastic bone metastasis in conventional group. In ABPC, bulky lymph nodal mass or bulky mass in prostate and pelvis more than equal to 5 centimeter, with Gleason score more than equal to 8 is a baseline presentation, and is often presented with low PSA value of less than equal to 10 at first presentation before starting ADT, or at symptomatic progression during ADT despite of high volume disease, and is often represented by ISC markers of neuroendocrine differentiation or elevated neuroendocrine markers like serum chromogranin A at initial presentation or during progression. And there is always a short interval period, usually less than equal to 6 months, between starting of ADT and AR independent, androgen receptor independent progression. So this is the aggressive variant prostate cancer clinico-pathological criteria. Any one of the 7 criteria defines ABPC clinico-pathologically. However, currently we are looking into the molecular signature of ABPC. So molecular signature of combined tumor suppressor defects, that means 2 or more alteration in TP53, RB1 or P10, either by ISC or NGS, defines ABPC molecular signature. So as I said, this can be determined by either ISC or genomic analysis. So we need to see what is the concordance between this ISC value and NGS for TSG alteration in ABPC molecular signature. So there are several studies where individual genes were studied, but this particular paper, they have seen that they have studied the ISC findings as well as copy number variation and single nucleotide variation and their concordance. So they used the Cohen-Kappa value. So for TP53, the agreement between ISC and loss of function transcription score was weak, but single nucleotide variation alone has the best agreement with LOFTS with a Kappa value of 0.5. For RB1, ISC alone yielded the best agreement, and for P10, both ISC and copy number variation has similar agreement level of 0.46. So ISC plus NGS together results 90% of determination of abnormal TP53 value, 70% of abnormal RB1 value, and 50% of abnormal P10. So this study concludes that ISC and NGS are complementary, but they can be used in isolation also for assessment of these gene alterations. So coming to the therapeutic implication of ABPC and this gene alteration, I will discuss 2 studies. One is published and another, the recruitment has been completed. So this study, which already discussed the methodology, so it's the cabazitaxel or carboplatin in metastatic castration-resistant prostate cancer, and they have shown that the overall survival and the PFS were particularly better in ABPC molecular signature group, either by ISC or ctDNA or any method using cabazitaxel plus carboplatin as seen in this forest plot. And there is a PFS improvement in with cabazitaxel carboplatin in ABPC molecular signature group, and there is a trend of overall survival improvement in intention to treat population. And coming to another study where the recruitment has been completed, and one site is our Varanasi center, where capivasertib, which is a AKT inhibitor, AKT pathway inhibitor. So capivasertib and abiraterone is used in metastatic hormone-sensitive prostate cancer with PTEN deficiency. Is CAPI-DELO 281 trial. I would like to highlight that in this study, the PTEN deficiency is being assayed with ISC instead of NGS. So a lot of work is ongoing in this field, that is the loss of TSG as well as aggressive variants of prostate cancer. So till now, from our discussion, the take-home message could be loss of tumor suppressor genes like TP53, RB1 and PTEN alone or in combination defines aggressive variant of prostate cancer and portends poor prognosis in both early and advanced prostate cancer. Phenotypically, they are expressed as small cell pathology, not exclusively, then lytic bone lesion, extensive visceral metastasis, low PSA, bulky nodal disease, neuroendocrine differentiation, and early androgen receptor independent progression. Both ISC or NGS alone or in combination can be used to detect the AVPC molecular signature variant. They are mostly resistant to single agent systemic therapy, but responsive to PARP inhibitor or AKT pathway inhibitor or platinum containing chemotherapy. And further research is required to precisely diagnose such entities, which is an unmet need till now. Thank you.
Thank you, Rhythm. So you covered everything in detail. The good part was that all the relevant predictive and prognostic information along with the therapeutic relevance was also covered. So I think I can go to taking comments from my teachers. Kumar sir, I would request your comments.
So, good, coverage of the topic. It was very nicely done. A whole lot of learning for me also. And I agree that in today's time, these molecular markers helps in many ways. And that's the reason this needs to be integral part of our decision making. And whole of those nuances comes in when we have these tests being available.
Yes.
That's all from my side.
Thank you. Thank you.
Go ahead.
So our entire pathology team. Yes, sir. Our entire pathology team is also here. So I will request Dr. Zakaria to give his comments.
Can I make a comment before that?
And,
can I?
Yes, sir. Sure.
So I think so. I need to congratulate your pathology department. I have told it for many other aspects. This was for your department also, and it's very heartening to see that Varanasi has taken initiative in more than one situation ahead of what we do at TMH. Keep doing it. I absolutely appreciate that. Okay, where patient care is required, where adapting newer technology is required for patient care, and I see that more than one situations where Varanasi has taken a lead. This is very nice to see. Keep up this work. Thank you, Akhil.
Thank you, sir. Requesting Dr. Zakaria for comments.
Thank you so much, sir. Prabhas, sir. Very heartening to hear this comment from you, sir. Thank you so much. And we promise that we will keep up doing the good work which we have been doing for the last few years. Coming back to the topic, we have started testing for P53 and P10 on immunohistochemistry, and we are in the process of validating after our RB1 antibody. Actually, we had indented RB1 antibody along with the other ones. I mean, we had P53 in-house from before, but there was some issue with the validation. So that's why we have not been able to start the testing of RB1 as of now, but we are in the process and hopefully we will do it very soon. We are not doing it as a routine practice. We are doing these on only when requisitions are being raised after the cancer, after the prostate adenocarcinoma or prostate adenocarcinoma with neuroendocrine differentiation has been, the report has been finalized. So that is the practice which we are doing, and we are doing only on the basis of ISC. We have not started or not doing it on a molecular analysis. One point I would like to just, the discussion part, which Dr. Ritam mentioned very nicely, very elaborately, the combination of the two procedures, immunohistochemistry and the molecular on NGS platform. So they could pick up the maximum cases combined relation to P53. So there is a point from the pathology perspective is that P10 loss indicates that it is molecularly also probably there is loss of molecular analysis. RB1 loss also on ISC is very clear. The issue with P53 ISC is that there is no defined cutoff as to what we call P53 mutated on ISC. There are very conflicting studies, and they have not, the results have not been able to establish a proper guideline as to when we call P53 mutated based on ISC. Like say, when we talk of ovarian, high-grade ovarian serous carcinomas, we pretty well know that there are 3 guidelines which we follow with regards to P53 mutation. And that has showed very good results when compared with molecular testing. The same has not been applied with relation to prostate carcinomas. That's why we do not exactly call it mutated when we report our findings. We just say that this much as P53 is positive in this much percentage of cells and what intensity it shows, because there are conflicting reports on what should be the guideline. So that is probably the baseline, the bottom line, because of which there is the combined modalities have shown pick up good number of cases with relation to P53, whereas as you can see, ISC and NGS has found to be complementary, or you can say almost show same results when picking up RB1 loss or picking up P10 loss. So maybe the P53 guideline needs to be looked at more in detail as to what should be actually taken off as a mutated when we are talking about ISC.
Thank you, Dr. Zakaria, for this comment. Yes, completely agree that there are some areas which are require further studies, further clarification. And a good point is that we already have a great data in from multiple studies, from multiple institutes, not just a single institute. Right? But I completely agree. P53 is a slightly gray area in this. So I think we are going to introduce HR very shortly in our lab. So where I have requested to include P53 specifically in the HR pathway, so that can be corroborated as well, because it might not be always possible to include all the 3 in the HR pathway, but at least P53 can be included. So we have requested the vendor for the same. So that will help us, because P53 being the most important gray area. Amit Joshi sir, requesting your comments on this entire discussion.
So I think we are just close on the moving to the molecular directed therapy, as in lung, that is already established. Breast cancer, it is already established years back. So I think, and we all know that even we started triplet to patients, and we generally discuss that the survival is going to be 5 years, 6 years, but we see that patient progress within 1 year, 1.5 years. Then, so I think time has come to integrate these molecular tests into the. The only thing is that at this point of time, do the guidelines advocates? So I think it's the matter of time. At some point of time, since the guidelines have not recommended, so we don't do it. That is not the case. We know that it is going to give benefit to our patient. definitely we should integrate like a breast cancer TNBC. I think I don't do breast cancer, but we know that even in the management of a TNBC, you take the grade, you take the MIB index of that. Although it was not gradually moved into guideline, but people started using the that in that decision making. So I think it's a time for us to integrate this and gradually adopt at least in a younger group of the patient where we know that the survival is not that great. Even in low volume metastatic disease, patients are not doing well. So I think it's time for us to gradually move. I think most important thing on the pathological aspect that they have to validate the test. So the trust on the test from the clinician to the pathologist, if that should be established, and then we start utilizing it in our day-to-day setting. Guideline, if we wait for the guidelines to come, by the time the guideline, the same question for PSMA PET-CT. We have started using PSMA PET-CT. The standard guidelines have now started saying some few lines about the PSMA PET at the baseline. So I think we are moving the transition time. And if you ask me, if it is available, will you incorporate in day-to-day practice in some patients? Yes, definitely. I would like to know these three mutations stated before planning any treatment in day-to-day setting. So it's, I think, a good move. And since if it is available through ISC, then the things will be easier for the pathologist to decide for taking the decision for any treatment. So I think it's a very important work, and definitely we should adopt or gradually start adopting this to the clinical practice.
Yes, sir. Thank you, sir, for this comment. So we have started to gradually adopt this in the routine practice. And there is a relevant question from Dr. Nishant as well. He asked whether a patient of HSPC with low PSA and heavy nodal burden presented, and it is AVPC actually. So can we consider carboplatin plus cabazitaxel like treatment upfront? So there is no definite data to add the platinum upfront till now, but I think some studies are going to look at it. But at least triplet therapy will be mandatory for such patients. Amit Joshi, sir, your comment?
So I think if the patient is
Sir, your voice got broke. So basically, carboplatin combination we utilize presently till now in second line in the CRPC setting, and it can be considered in the upfront setting if the patient is very young, below 50. We see very sometimes we come across young prostate cancer as well. So below 50, it is the patients are able to tolerate the docetaxel plus carboplatin combination. So we utilize it sometimes, but it is not a routine practice still.
But can we do it as he asks? Is asking, can in a aggressive variant? Can we start it to first line?
We can utilize it, but we'll keep cabazitaxel for the later line.
Sorry, I lost the connection. So I will complete that.
Yes.
That in a younger patient population, although the patient classifies into the low volume risk, but if any two of them is positive, definitely I would like to discuss regarding this data. The only thing is that we have to select the patient, but we cannot do a cabazitaxel in an elderly patient. In a young patient, 55, 60-year-old male, otherwise fit, no major comorbidity, fitting into the low volume, but still I will definitely want to use in this. We know that the prognosis is going to be poor, so I will like to use.
Yes. Thank you, sir. Thank you, sir. Final comments, Mr. Sir.
So I think now we have moved to ahead. Initially, we just see the Gleason score and initial baseline PSA to see the status. So now we need to we should integrate the molecular things for the getting best treatment. And we should examine each case of CA prostate in a very particular way, and especially in the case of first relapse, or some any unusual clinical feature, unusual age, some bulky tumor thing, some unusual pathology, and it will help the starting the treatment upfront.
Thank you. So thank you to all the participants. A special thanks to our pathology team for taking active participation and taking out time for this discussion.
Thanks. Well induced. Thank you.